Now, moving on, the next speaker is Jonathon Ball, who's from Sydney. He works at Royal North Shore, which is a major trauma centre for spines, and has been doing many years of trauma spine now. He'll give us an update.
Nice. Thank you, Andrew. Good afternoon, everyone. I'd like to thank the organisers for the invitation to speak about decompression surgery in acute traumatic spinal cord injury. I was given a pretty wide brief to talk, and I thought my time was pretty short, but now I might have a few extra minutes and won't race as much. So firstly, I'd like to briefly talk about some of the newer evidence in terms of timing of surgery in spinal cord injury. But then when I come to the indications, which was the second part of the brief I was given, I'd like to wind it into a bit of an argument about why we should avoid a nihilistic approach to spinal cord injury. I should have read the instructions on that. So I have some disclosures of industry relationships, and they're listed on this slide, but I don't think that they bear much relevance to this particular presentation. The father of modern spinal cord injury care, Sir Ludwig Guttmann, cautioned against surgical treatment for spinal cord injury in his landmark reference text. He described surgery for spinal cord injury as a surgical indulgence and stated that conservative management was far superior. But what I hope to show now is that there is now increasing evidence that surgery, decompressive surgery for spinal cord injury can lead to benefit. So in the first part, it was to talk about timing, and the most comprehensive recent evidence available for early decompressive surgery in spinal cord injury comes from this pooled analysis of over 1,500 subjects that were drawn from 4 large data sets: the Staskus dataset, NASCUS-3, the SIGEN, which was GM1 ganglioside, and the NACTIN, which is a North American registry. And those patients were then dichotomized into either earlier or late surgery, depending on whether it was more or less than 24 hours. And if we look at those groups, they were very well matched in terms of age and gender. In terms of the distribution of AIS grade, it was evenly matched. The main difference between the two groups is that there is a slight predominance of cervical level injuries in the early surgery group, and that probably reflects a degree of selection bias. If we use the most blunt outcome scale or assessment that we can, and that would be a change in your AIS grade, the pooled estimate for the combined odds ratio, so that's the likelihood of an improvement in your AIS grade, it was 1.49. And so that fell in favour of early surgery. And the graphic at this, on the bottom part of this slide, in the red bars is actually early surgery, and there's an increasing proportion of lower grades, the statistically significant in those patients who had early surgery that is less than 24 hours. If we use a more sensitive assessment of outcome, that being your INSCI motor score, there was a mean difference of 4 points on the motor scale, again favouring early surgery. The MCID for motor score hasn't been established, but a single motor level is 5 points. And so it's very likely that a motor score of 4 points is going to be functionally and clinically significant. And I would have previously argued that that's most relevant to cervical injuries, where a single level of motor improvement is very functionally important. And that still holds true. They looked at just cervical level injuries and just the upper extremity motor scores and demonstrated that that improvement occurs in the upper extremity motor scores, so close to the level of the injury. But what was interesting is they also took the thoracic injuries and looked at the lower extremity motor scores and demonstrated improvement in those as well. So that even in thoracic injuries, and I'll come to nihilism later on, but even in thoracic injuries, there can be functional improvement in terms of improvement in motor scores in the lower extremities. If you then don't take time as a dichotomous variable, but made it a continuous variable and plotted that against motor improvement, there was a rapid decline in the magnitude of motor improvement over the first 24 hours. And so that red line illustrates where it starts to then plateau around the 24 to 36 hour mark. Just at a local level to see how well we were doing, we've recently audited at both of the New South Wales units some of the outcomes of acute spinal cord injury. And so our median time to theatre is 0.42 days, which is about 10 hours. The record is 0.12, which is 3 hours from injury to theatre. And then it does blow out when there's complex transfers that occur. So the takeaway in terms of timing is really that early surgical decompression in our most recent evidence is associated with improved sensory motor outcomes after spinal cord injury. And that there is that decrease after 24 hours or through 24 hours is actually steep and continuous. And so after 24 to 36 hours that we see that plateauing. So in terms of indications, the question then becomes, well, for whom should we consider surgery? And different papers have assessed surgeon attitudes to surgery for spinal cord injury. In this 2018 study of Dutch surgeons, surgeons were almost twice as likely to offer early surgery to incomplete spinal cord injury compared to complete spinal cord injury. So the first two blue bars here represent having surgery within 12 hours, and only 30% of surgeons would offer surgery for an AIS-A injury, but more than 50% would offer surgery for AIS or better. And so we know that the INSCI examination will influence the timing of surgery and often other treatments that we offer as well. But I would argue, this is my argument, that that's a poor practice. Because the INSCI exam is poorly performed and understood, it's variable over time, and you can have improvement in complete injuries. So in terms of doing INSCI poorly, this is extracts from different entries in one patient's medical record. And so at 7:25 in the evening, when they came to hospital, someone's written a little bit about their neurologic findings, maybe a motor deficit at C7. At 11 o'clock, someone says it's a clinically complete C6 injury. 8 minutes later, someone says it's now a complete cord injury at C7 level. At 1:45, when I came in to enroll them in a trial, I did the INSCI exam properly, and they were a C6 AIS-B. And it influences our decision. If you read one of those notes, it also says, oh, we can do the ACDF tomorrow morning. There's no urgency tonight. When we again audited the outcomes in our service, we found that 82% of documented neurological examinations are actually inadequate for calculating a proper INSCI assessment. And why is that? It's a complex exam. It takes time. It's difficult. It's poorly understood. I ask every registrar for the definition of a complete spinal cord injury, and not one, when they first come, and not one has got it right yet. The components of the anal exam, there's 3 components. Not one has got that right yet as well. And so that's bared up by literature. This was a study where they looked at people before and after training in INSCI assessment. And it's about less than 50% of people can accurately classify the completeness of injury, and less than 20% can accurately identify the motor level before training. So in terms of that was the first thing, it's poorly understood and poorly done, but secondly, it can vary over time. So we know that the best prognostic factor is your INSCI exam at 72 hours. So we have to make this decision before 72 hours. And this was a study where they took 85 patients who were classified as AIS-A, so complete motor and sensory injuries. And if you're examined within 4 hours of your injury, there was a 79% chance that your classification would change at follow-up. If it was between 24 and 48 hours, there was only a 50% chance that you would change. So there can be a very great variability in the examination and classification within the first 24 hours. So we have a poorly performed exam that's variable as to when we actually do it. And then there's the argument that complete injuries can get better. So in that same study by Evanue, those 85 subjects, 60 of them had their exam within 12 hours. And at follow-up, 28% of them had a more than 2 grade change in their AIS. So that complete injury that we're not going to operate on until the next morning, we're potentially denying them treatment. Again, trying to find some local data. The RISCUS trial was just completed. I can't talk about the results until it's published, but just in terms of examinations of those patients, in our group, we had 8 who had an AIS-A within 12 hours. And again, 38% of them had a more than 2 grade change. So just using the most blunt assessment, complete injuries can get better. If we come full circle back to the Badawala paper I spoke about earlier, even if someone doesn't change their AIS grade, they can have an improvement in motor function. So we know that complete injuries can get better over time. So using the INSCI to guide the timing of surgery is probably poor practice for those reasons. It's poorly performed and understood. It's variable in terms of its predictiveness of where you're going to end up, depending on when you do that exam. And even if someone is classified as complete, there's a significant chance that they can get better. And so from out of this, there is evidence that early surgical decompression within 24 hours is associated with improved sensory motor outcomes. And we should all challenge our biases that we have in the treatment of these injuries and recognise that complete injuries will deserve our complete care. Thank you.
Thank you.
Right.
Thank you. Jonathan, you've got a second talk to give.
Yeah, do you want me to introduce the second speaker? Yeah. Yeah, if you want.
Yeah, go ahead.
Now, I've got a question for you. So, should we decompress at the hospital where they present?
Yeah.
Or should we transfer them to you?
So like everything, there's going to be a balance in these things. So out of that study, which was the access to care study that New South Wales Health did of all the spinal cord injuries over that 3-year period, one of the other things that came out of that is that your complication rate is higher if you have surgery in a non-spinal cord injury centre. Pressure areas, pneumonias, DVTs, PEs, all of those things are higher. And so we have to then have an argument about whether we value neurologic outcomes over the length of stay the patients have. Within New South Wales, there is a redesign process going on at the moment where they're trying to move to a hub and spoke model so we can try and delineate which of the injuries would be better treated in a quaternary centre and which may be able to be treated outside of that. That's actually as much trying to improve rehab services outside of the big centres as opposed to surgical decision making, because another study that's been done showed that I think it's 30% of patients who may need specialised spinal cord injury rehabilitation services in New South Wales don't access it. Because that's quarter equina as well and all those sorts of things.
Jonathan, one of the issues that Westmead has is getting access to rehab post surgery or post injury, and majority of times we transfer patients out not because we can't do it, but because it's actually quicker for the patient to get the multidisciplinary approach. With the redesigning of the network, I mean, in the past we would occasionally call you up and say, "Hey, we got this patient here. Do you want us to operate and you take over, or do we just send you the full, cat grab sort of situation?" Do you think that cooperative approach is going to be probably the next?
Well, I don't want only a few people here from New South Wales, so talking about our redesign might be a bit boring for some, but in general, a cooperative approach, I don't think you can argue against in any sphere of medicine, and particularly in this, I think that's a very worthwhile approach as well.
Justin?
That was all comers regardless of their treatment. Yeah, that portion of the argument is really just to say that when you see someone at presentation and they are AIS-A, I know, if I go back 10, 15 years, there was probably an attitude, it's complete, there's less drive to do something. Maybe in some cervical injuries we'll do more. And so that portion of the argument is really just saying that just because someone's AIS-A, it's actually an inaccurate exam at that time. It may well change if you did it in 12 hours or 24 hours later. And then secondly, that even within that group, it's actually not as pessimistic as we may have historically thought, that there's a significant chance of that person improving 2 or more grades. I cannot tell you that off the top of my head, but I can find that out for you, Justin. No problem.
Any more questions? Oh, there's one. No.
Gentleman here.
Yeah.
If the grading system from your talk, if it's not accurate, reproducible, and not influencing decision making, where's the role for that?
Yeah, that is something that I personally am kind of struggling with, whether we should actually aim to do an INSCI at all. The ISCOS, which is the Spinal Cord Injury Society in Asia, the American Spinal Injuries Association, who developed the INSCI, have now got an expedited INSCI or an e-INSCI, recognising the troubles with this, where you can skip a few steps and have a quicker system. But even then, it has some limitations and says if you come up against these barriers, you have to do the full thing anyway. At the other end of the spectrum, there was a proposed assessment by Peter Batchelor in Victoria, which was when he was trying to set up a cooling in spinal cord injury study, had a rapid assessment for spinal cord injury just to try and work out what type of injury it was, but it's probably oversimplified. And the truth is, I think that from a surgical point of view, rather than a rehabilitation point of view, there are better assessments we could propose and validate in that earlier stage following spinal cord injury, rather than, the INSCI is essentially a rehab exam. It takes an hour to do at 1 a.m, and your heart's not usually in it.
Thanks, Jonathan. Might move on to the next.
Yeah. So the next presentation was the results of some research that was done looking at the association of MRI findings and neurologic grade after spinal cord injury. The same disclosures apply as to the last presentation. I don't think they bear much relevance to this paper either. And I'd like to acknowledge the co-authors on this paper, Dr. Lisa Sharwood, who was working at the Colling Institute in the Rehab Research Institute, Professor Middleton, who's the director of the statewide spinal cord injury service, Dr. Dinesh Varma from Victoria, who did the radiology assessments, and Dr. Vincent King, who did some of the initial work on this analysis. Spinal cord injury, as I've already spoken about, is a severe neurologic injury, and there's often uncertainty regarding prognosis in the early stages following injury. As clinicians, we seek greater sophistication regarding stratification of spinal cord injury to guide our treatment decisions, and patients seek a better understanding of their injury prognosis as they face an uncertain future. So while neurologic grade, as I've discussed before, is the most accepted prognostic factor, some studies have looked at MRI findings, such as haematoma and cord compression, to provide greater prediction. And so this study aimed to add to that body of knowledge by combining analysis of multiple factors and also examining thoracic injuries together with cervical injuries. So the aim of the study was to determine if the presence of spinal cord haematoma and or cord compression on an MRI scan performed within 24 hours of injury was associated with neurologic status after acute traumatic spinal cord injury. And so this study is part of an observational cohort study of 163 injuries between 2013 and 2016 in New South Wales in individuals aged over 16 years. Clinical data was collected, including age, gender, mechanism of injury, the actual injury details and admission details and their treatment details, including the INSCI score performed within 24 hours. Administrative details regarding cost of treatment and length of stay was actually, and readmissions was got from the New South Wales Health Record Linkage system. And so there were 120 subjects for whom there was full MRI and INSCI details available, and those individuals formed the cohort for this particular part of the study. The MRI scan was examined by an independent and blinded radiologist for the presence or absence of haematoma, which was then measured in terms of its maximum craniocaudal length. Spinal cord compression measures, including the canal stenosis itself and the actual maximum spinal cord compression, were measured. And then from the INSCI exam, we tried to take their AIS grade from A to D at presentation and from A to E for follow-up. The population of 120, the mean age was 51. That probably reflects the increasing proportion of older patients sustaining spinal cord injury. What hasn't changed is the male predominance in this cohort, motor vehicles and accident and falls actually accounting for the majority of the injuries, and a 2-to-1 ratio of cervical to thoracic injuries, with the majority of the population having surgical intervention. 48 of the 120 patients, that's about 40%, had a haematoma on their MRI scan. The other 60%, or 72, had, that's about 60%, had no haematoma. Of those with a haematoma, 85.4% presented as motor complete. So that's AIS A or B, compared to 47% without. At follow-up, 66% of the haematoma patients remain motor complete, compared to 30% of those in the no haematoma group. And so the differences between these groups in terms of the severity of injury associated with haematoma were considered significant. Patients with a haematoma were more likely to present and remain with severe neurologic injuries. In both groups, about a quarter to a third of subjects who were initially motor complete did improve, as we were discussing in that earlier presentation. However, the haematoma didn't predict which ones were going to get better. There was a similar rate of improvement in both groups. So it predicted the initial severity of injury, but not the chance of improvement. What did actually predict improvement was the degree of cord compression. So in this graphical representation, on the right side are the patients who improved in their AIS grade, and on the left-hand side are those who did not improve. And then there's two columns, those with haematoma and not. And so we can see in both groups, there's a fairly even spread of patients with and without haematoma in both groups. But what is interesting is that no patient who had more than 25% cord compression actually demonstrated improvement. So all the patients in the improvement group had less than 25% cord compression, whereas in the no improvement group, there were patients with a wide range of cord compression, but including those from 25% and higher. To investigate these factors together, an ordinal regression, a logistic regression model was fitted, likelihood ratio tests were used to try and reduce the model down, and the final model found haematoma and the thoracic level of injury were the most significant predictors of poor outcome at a univariate level. But then another model also retained mean spinal cord compression. And so using this model, we can predict outcomes to some degree. So if we have the probability of an AIS-A injury, that's motor and sensory complete, in a cervical level injury with no haematoma and less than 25% cord compression, it's about 17%. If you add in some cord compression to that, so no haematoma, but more than 25% cord compression, the odds of being AIS-A is about, so this is a presentation, is 30%. If is cord compression and a haematoma, then it's about a 67%, 2/3 chance that you're going to present as AIS-A. And the same analysis was also done for follow-up AIS grades with very similar findings, but including the worst injury was a thoracic level injury with haematoma and more than 25% cord compression, and your chance of being AIS-A, either a presentation or follow-up approach 90%. You can graph that. Lisa loves statistics, and Dr. Sharwood, and so she produced these graphical models of this. And so each of these little plots is changing one of those variables. And so if we look here in the blown up pictures, the chance of your follow-up AIS grade being A, if you actually have more than 25% cord compression with a thoracic level injury, is about 66% with no haematoma and about 88% with a haematoma. Cervical injuries perform a little bit better in that. So in conclusion from this study, we found that haematoma was associated with more severe neurologic grade. The actual improvement wasn't associated with the haematoma, but was associated with spinal cord compression. And so together, the significant predictors of injury were the presence of haematoma, the presence of significant spinal cord compression, and the level of the injury, cervical or thoracic. So thank you once again.
Any questions for Dr. Ball?
Dr. Dandy.
Dr. Dandy.
Yeah, so when it comes, thanks, Gordo. When it comes to decompression, I didn't really have time to talk about the rationale behind decompression, and so we can get into a talk about spinal cord perfusion pressures in terms of improvement. So my main takeaway from that is maybe it is okay to have a little bit of a nihilistic approach for some thoracic cord injury. So if it's obvious, has all those bad factors, and you're looking at a 90% chance that regardless of, well, it may be regardless of what we do, that they end up complete. Maybe that is the one injury where I would be more pessimistic about things. But often these are associated with a fracture, and so you're there going to fix it anyway. And if you're there fixing it, is there much harm in doing a laminectomy? The argument that flows on from that when you get spinal cord perfusion pressures is whether a laminectomy is enough. So when you measure, I haven't done it, but the studies where they've measured either subdural or intraparenchymal pressures at the site of injury, doing a laminectomy, the cord tends to swell to that point, and it doesn't the pressures remain quite high at that level, and so high that you probably don't get adequate perfusion through that area. And so in London, Marios Papadopoulos, who drives most of that perfusion research, is now doing duroplasties to try and further decompress the cord. So I don't think it's changed my view that much, because I think there's a lot more to it than what we know. But just in terms of initial prognostication, I think that's how the takeaway I would have.
Thanks, John.
No worries, thank you.
Thank you.